Well, my primary specialty is orthopedic oncology, and this is a specialty basically that deals with bone, joint, and muscle tumors. And even though the title oncology sort of lends itself to cancers, the vast majority of these are not cancers, thankfully. The vast majority are benign. I did a 2-year fellowship at the Mayo Clinic, basically looking at various types of tumors in all age groups from infancy through elderly, and looking at tumors that involve the bone, the joint, the muscle. So in basically the specialty, we specialize in diagnosing, treating these conditions. It's a different group of patients. If you have a sports injury or arthritis, or that's a big problem. These people, though, come in really anxious, worried about cancer, worried about their lives, whether their bone is going to break, if they have a weakened bone, for example. So they're typically pretty anxious. I really treat these patients in a special category. If someone is told that they have a tumor, I try to get them in quickly, within a week or 2 at the very most. The reason I do that is not because necessarily they're all cancers, because again, the vast majority are not, but I like to give people peace of mind. I like to look at the x-rays, talk with them, reassure them if it doesn't look dangerous. If there is something worrisome, I like to get the biopsy done quickly, let them know what they have, what their options are. The first big question that we always ask, is it a cancerous tumor or something dangerous? And tumors that are cancerous have certain characteristics that we look for, and then if we're worried about any of that, we usually get a minimally invasive biopsy called a needle biopsy to gain a diagnosis. Thankfully, the majority of these tumors are benign, and so if you have a benign tumor, we basically look at function and pain. If it's a benign tumor that's not causing you any problem with function or pain or not weakening the bone, it can be left alone quite often, and we usually just follow it up with new x-rays or a new MRI in a few months just to follow the issue along. If there's a benign tumor, though, that causes pain or dysfunction or presses on a nerve or even weakens the bone, then oftentimes we'll recommend that it's removed. On occasion, we'll have to shore up the strength of a bone or bone graft, or use plates or screws to make the bone stronger in situations like that. Bone and joint cancers, thankfully, are very uncommon, but they do occur, even in young children through elderly. In cases like that, it's often that we have to actually remove the bone that's involved with the cancer. And so part of the specialty that I'm trained in is being able to reconstruct. So if we have to remove part of your thigh bone or your arm bone, to get rid of the cancer, then we have some tools and tricks to reconstruct those without having to amputate the limb. As early as 25 to 30 years ago, most cancers were treated with amputation right away, followed by chemotherapy, and survival was really low. Thankfully, in the last 2 or 3 decades, most people with bone cancers keep their arms and legs, and the survival rates are really quite high, in the 70 to 90% range as treatments exist now. And so there's been this nice progression over the last few decades in my specialty of more limb-sparing techniques that don't involve amputation, improved function afterwards, and improved longevity in terms of survivorship and even cure from their cancers.